Today we're going to be continuing our case of the 7-year-old boy with a pulseless supracondylar fracture. Having examined the patient with an A-B-C-D-E approach, examined the median, radial and ulnar nerves, and performed a thorough vascular examination of the brachial artery and radial and ulnar pulses, you've established that the patient has a cold, imperfused supracondylar fracture which is pulseless. This presentation has been adapted from a fantastic paper by Badouk Behi et al. On the management of the pulseless supracondylar fractures, which was published in the Journal of Bone and Joint Surgery. So, you have a displaced fracture with no pulse and signs of impaired perfusion. This is a surgical emergency, and at this point you need to make sure that the patient is fasted, the patient has had adequate analgesia. You need to contact the emergency theatres in order to book the patient on and ensuring he's first on the list, as this is a life and limb-threatening injury. After this, you need to contact the vascular surgeons to ensure they are on site during the reduction, because vascular intervention may be required. At this stage, it is of paramount importance to perform a closed reduction in the operating theatre. Following closed reduction, there are two options. It is imperative to assess vascular status. The limb can be well perfused and pulseless, or at this point it could be poorly perfused and pulseless. If after closed reduction the limb is poorly perfused and pulseless, which is manifested by a pale hand, cool peripheries, prolonged capillary refill time, pallor, and severe upper extremity edema, you must immediately inform the vascular surgeon, proceed to explore the brachial artery alongside the vascular surgeon, and perform percutaneous pinning. There are several reasons for a pulseless supracondylar fracture with impaired perfusion. The fracture may be stretched or kinked over the displaced fracture fragments. There may be an intimal tear or transection of the brachial artery. A thrombus and a hematoma can also contribute to pulselessness and inadequate perfusion. And finally, a vasospasm of the brachial artery is a common cause of pulseless supracondylar fractures. Following open reduction, percutaneous pinning and brachial artery exploration, it is imperative to keep the patient in hospital for compartment syndrome observations. What if after closed reduction the arm is well perfused and pulseless? The arm is pink, cap refill is less than 2 seconds, and the peripheries are warm. This requires urgent treatment with percutaneous pinning. Following on from this, the reduction can either be acceptable, in which case you will repeat the vascular exam, or the closed reduction is unsuccessful, in which case you will discuss the case again with the vascular surgeon and proceed to explore the brachial artery and reduce the fracture by open reduction. If the reduction is acceptable, following closed reduction of the said fracture, and the limb is well perfused and the pulses are present, the limb can be well perfused and can be pulseless, or the limb can be poorly perfused and pulseless. In option 1, in a well perfused and pulsed limb, keep the patient in for 12 hours, ensuring there are no signs of compartment syndrome. If they're well perfused after 12 hours and there are no compartment syndrome, you can discharge the patient. In the well perfused but pulseless limb, the child must be observed for 48 hours. Common causes of lack of radial pulse in a well perfused child can be attributed to a brachial artery spasm. This often does recover, but it is imperative to keep the child in for 48 hours. If after 48 hours this child is well perfused with no evidence of compartment syndrome, he can be discharged. In the well perfused and pulseless child, following keeping him in for 48 hours, if at this point, at any time, he becomes poorly perfused and starts to develop compartment syndrome, contact the vascular surgeons to perform an immediate vascular exploration plus minus repair. If you are concerned about compartment syndrome, it is acceptable at this point to consider a fasciotomy. Let's go back to this scenario where we reduced the fracture by closed reduction and we repeated our vascular exam. The limb is poorly perfused and pulseless. At this point, you should contact the vascular surgeon for open exploration plus minus repair. Thank you very much for listening to this podcast. The next station in the workbook will go through various scenarios where you can apply these skills. Thank you very much.